Good afternoon, everyone. Thank you for joining us for Advanced Echo Teaching. We're going to go through a lot of cases today, or as many cases as we can in about 45 minutes. And for those doing the exam, we'll focus on you a little bit, but we'll see how we go. Right. Why don't we start with a relatively straightforward one? Who would like to start with? Louise, would you like to start with this one just to warm everyone up?
Can I get a bit closer?
Absolutely. And if anyone...
I need to peer at the screen.
Fantastic. And if anyone can't hear us talking, because maybe I should let the person who's in the hot seat, do you want to come and sit here? Because then you're close to the microphone. I'll swap seats with you. The hot seat can be the movable one. How about that? So you can sit in that one. I'll sit in the fixed one.
Okay.
We've obviously rehearsed this quite vehemently. All right, here we go. So this patient is 72 years old, known to have an aortic valve replacement. They're in the ICU, and the question that we've got is query aortic regurge, query valve dehiscence. All right, so we're going to start with...
Oh, it's a toe.
Yes.
Oh.
Oh, it's a good one for looking at aortic valves.
Okay.
Why don't we start with this one? This might be interesting. Yeah, let's start with that one. So what is this view? What does it mean? And what do you think of the numbers?
So this is the transgastric 5-chamber view with the sample gate going through the Lvot and not really getting the closing click. Well, in fact, you're probably getting both clicks.
And I'll say it's continuous wave Doppler. Sorry if that's not clear.
Yeah, no, it's continuous wave Doppler because the peak velocity is at least 3.2 meters per second.
Excellent.
Which means that there may be significant obstruction. Now, if this is an aortic valve replacement, then you expect a degree of increased trans-aortic pressure gradient that is part of the function of a normal valve. However, 3.2 suggests that it may be a little bit more than is expected for this type of valve, and you would have to look it up.
Okay, is there anything, you said it could be obstruction, are there any other causes of a raised gradient?
So if it's continuous wave, it could be anywhere along the line, as it were, that has the increased velocity. So it could be dynamic LVOT obstruction, or it could be subvalvular stenosis, or it could be a narrowing of the aorta after it passes through the valve. No, it doesn't really tell you where it is.
If this was some form of dynamic obstruction, would that fit the pattern of it?
No, because you wouldn't expect clicks.
And you'd expect late peaking jet. Cool.
Yeah.
All right. So anything else other than, well, you've mentioned anything else, particularly with the valve itself? So you've talked about obstruction of the valve. Anything else to do with the valve?
Well, do you mean expanding on obstruction, or do you mean talking about something else?
So
if it's a hyperdynamic state, then
nice,
you would expect higher peak flows.
Very nice. So we've got a heart rate of 110, so it could be a hyperdynamic state. Yep. So you could expect higher flows if the LV is working harder. Anything else? What else could raise a gradient other than obstruction that can make
high flow state?
Yeah, high flow state, and also more blood. So if it's a greater contractile force, it will make the flows higher.
A high flow state.
And if you've got more blood, why could you have suddenly more?
Oh, if you had significant aortic regurgitation.
Very nice. Thank you very much.
That's all under high flow state.
Fair enough. But then you got to say AR.
Yeah,
nice,
AR.
Nice. Kind of giving the game away a little bit on what the case is about, and the fact that I think the title of it was Query AR. Nice. All right. So next thing. So describe your findings for this and tell me what walls you see of the left ventricle.
Okay, so this is the mid-esophageal 4-chamber view, which shows me the... Hang on, I've got to go back to my parasternal long and then work it back from there.
Yeah, that's right.
So infroseptal and anterolateral walls of the left ventricle. And on the left-hand side, we can see the right ventricle.
Excellent. Which valve is that?
That is the mitral valve.
Which leaflet?
Oh.
So if you ever get stuck, where's the aortic valve?
So where the cursor is, the aortic valve is up under here.
And what's always next door to the aortic valve is the
anterior mitral.
Anterior
no,
mitral.
No, that's
leaflet.
the mitral. Nice. So I was thinking you were asking for A1.
Oh no, just tell me if it's anterior, posterior.
Anterior on the left and posterior on the right.
But now you brought it up. Is it A1, 2, or 3?
Oh.
And when in doubt, always say 2.
It must be A1 and 2.
Yeah, but this particular is going to be A2.
Oh, A2. All right.
Nice. All right, fantastic. Great. Let's go to.
So this is a slight. If this valve is a metal prosthesis that is just a single tilting disc, otherwise it's an oblique view of the long axis view.
That's correct. It's actually. Let me see if I can find you a better one. That's rubbish. I think I got a better one. Sorry, let me. Obviously, I've prepared this. Here we go. That's a good one. All right. So this is at 120 degrees, mid-esophageal view. Can you just tell me what you can see?
So this area up here is left atrium.
Excellent.
This is mitral valve.
Yep.
This is the anterior mitral valve leaflet.
Very nice.
Including A2.
Nice.
And this is the prosthesis.
Excellent.
And it is cast. There is probably some metal across there casting a shadow, which means we don't actually see the actual function of the prosthesis. What we do see is turbulent flow going in and regurgitant flow coming back. So that would be at least moderate, possibly severe. It would be severe if you took it according to the height of the regurgitant jet, according to the total LVOT distance.
Very nice. What are the limitations of that measurement? So sorry. So
it's only one jigsaw piece.
Excellent. It's one jigsaw.
So you need to consider everything. So you would want to try and get a vena contractor. You would want to try and get. Well, you won't get a piece on that because.
No.
No. Yes. No.
No. So vena contractor. What else?
But also the effective regurgitant volume and the effective orifice area.
Okay. Anything else? So we talked about. So if you're worried about moderate or severe regurg, you talked about. We'll talk about the problems with this measurement in just a second. You've also then mentioned vena contractor, estimated regurgitation volume, and estimated orifice area, and fraction. We're not going to, just in the meantime, time, we won't talk about those. Anything else for assessing the difference between moderate or severe regurg?
The color jet. So
the color jet, nice.
Duration and the length of the color jet.
In the duration and length of the color jet into the LV, you mean?
Yes.
Okay. Anything else? For moderate versus severe aortic regurg. Again, think through all Doppler parameters. So we'll start. You mentioned color Doppler. You've mentioned that LVOT, filling the LVOT, and particularly you can look at it on M mode.
So you'd be looking at the continuous wave Doppler.
Nice continuous wave Doppler.
And you would about pressure half time.
Fantastic pressure half time. And then the next one is going to be pulse wave. You haven't really talked about pulse wave Doppler. Anything you can do with pulsed wave Doppler to look at moderate versus severe aortic regurg? And anyone from the crowd can shout out to help. Flow reversal where?
Aorta.
Fantastic. Whereabouts in the aorta?
Ascending.
Yeah, it's actually yeah, and it doesn't really.
Is it?
The abdominal one's most specific, but yeah, the aortic root is often, I think, the one that we can get looking for diastolic flow reversal.
Can you actually do Doppler in? No, that would have to be upper esophageal level.
Yeah, so you can try and do a little bit of
No, but if you're doing a toe, you'd want to do it in the same. Yeah. So in the upper esophageal level, when you get the short axis, no, the long axis of the ascending aorta.
Yeah, and also just you pull the probe up and Passed and look to the right. Yep.
Yep.
Fantastic. Okay, so the last question. If you're happy, do you want me to still carry on hassling you, or do you want to pass on? I'm going to want to know the inadequacies of
Depends
this.
if you want an answer or
Yeah,
not.
I think you're doing great. So what are the problems with this measurement? So you mentioned that you can look at the color filling the LVOT.
It's gain dependent.
Gain dependent, nice. Yep.
It's also, well, it's not really angle dependent as such.
Yeah, nice one dimension. And the next thing I was going to talk about is it's very so we've got
Jet's not central.
if it's jet's not
If
central,
it's eccentric,
this
it's,
eccentric,
no,
you've
because
got it.
if it goes across underneath, then
Nice.
you'll get a false impression of.
And that's going to be the same. So just for those doing the exam, you know, this is very much, I think, open and fair game. You know, we're talking about doing the basics extremely well. And for me, the basics are going to include recognition of severe valvular abnormalities. So the big key, I think, in this, if you see cases like this in the exam, and I love putting them in the exam because, as I say, it's really important to do the basics well. We'll probably show you a picture like this. First of all, you would be expected to recognize that you've got a bioprosthetic aortic valve replacement, because you can sort of see things flapping about, but there's also this artifact in the background, the shadow artifact. What are we seeing in here? What's in the LVOT? Anyone can tell me? Is it normal? How about that?
No.
No, it is not normal. All we've been told is query AR. They've got an aortic valve replacement. Query dehiscence. Fantastic.
So it's off center.
Yeah.
As in it's oblique rather than being.
We don't actually know what is going on there because we can't see it because of the metal struts. Remember, you've normally got those 3 metal struts with some kind of pericardial, stuff that's making up the valve in there. And then something is flicking through. That could be a valve, it could be infection, it could be whatever, but it is significantly abnormal. Now, straight away, when you see that, you've got to be thinking I'm associated with severe AR, right? So then when I show you that, the answer should be, well, I've got a significant 2D abnormality. I've got significant color abnormality. Before I even start talking about vena contracta, estimated orifice area of regurge, fraction, or whatever, we have got severe AR. The next view, if you're asked for one for me, is I want to see if we've got hollow diastolic flow reversal. Because those things are sort of the one after the other. Because the hollow diastolic flow reversal, you can't really mess up, right? It's hard to do. And having said all that, I really hope I did it on this. Let's go and have a look. I think it was me who was doing this, so I should have done it. I think that's it. Yeah, that's it. It could be a pulmonary vein, but I'm not sure. Hang on a second. Here we go. Phew. All right, so looking at hollow diastolic flow reversal. Nice. Yeah. So I'm in the descending aorta here. I've probably not got the best angle in the world. Maybe I could, you see, I've then gone on the second one trying to get a better angle. And here we've got systole from the beginning of the QRS to the end of the T wave. So that's flow going away from the probe. So that means that blood flow is going in which direction? Ben, is blood going from right to left or from left to right?
During diastole?
No, just in this image.
Yeah.
It's so I'm at 90 degrees. I'm in the descending aorta.
Yeah.
I could have put color on it, but I didn't. And then I've got my I've got the gate right on the left of the screen.
Yeah.
So my question to you, based on this profile, is the blood going from right to left or left to right?
So you've got flow coming towards the probe during diastole. We've got flow reversal. You're in the descending aorta. So flow has to be going right to left. Fantastic.
So here during systole, blood is away from the probe. So if blood's away from the probe during systole, it has to be going in that direction. So it's right to left. Very nice. And then the hollow diastolic flow reversal is not normal here. All right. And they classically talk about it being 0.2 meters per second associated with severe AR when you're in the descending aorta. And again, the angle's not perfect. So I think we are meeting that criteria. And again, tick, 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 severe AR. And then the last thing you got to remember is you're in a DDU exam, which is for clinicians. So whatever the story is, what would you say to the examiner after you've given them that spiel?
This needs clinical correlation with results of blood cultures, with maybe you would have done more views of the actual function of the prosthesis to see if it's actually dehisced, and you would have done specific views looking for abscesses or perforation of the tissue valve leaflets.
Nice. Is any of this going to get better with antibiotics and supportive therapy, which you can provide in the ICU?
Not if it's dehisced, so
Fantastic.
they need referral to a cardiothoracic surgeon.
Yeah, and even in the, even if it's not dehisced, because I think this valve is actually well seated. I probably haven't given you enough pictures, but you can see that the valve looks well seated, but the weird bit is the stuff that's flapping around off it. So I think it's infective endocarditis. But with that kind of thing flicking around in there, there's something majorly wrong with this valve. It's early referral with the cardiac surgeons thinking about where we go with this. Nice. So it's that kind of speed for the exams. It's kind of that point and shoot stuff.
Hiding.
Hiding. You don't have to.
No, sure.
Oh, this is a good one.
Will it tell me the answer on here?
Say
A
you
little
don't
bit.
have to.
A little bit. No, it does. It's fine. There'll be.
It won't help me all day.
So I'm looking for BN. Yeah. So we've got a gentleman with urosepsis. He's in escalating inotrope requirements. Query cardiac function is the reason we did it. Oh, you did this one. All right. Let's not give you that one.
No, but that was a while ago. You won't remember, will you, Andrew?
She remembers everything. She remembers everything.
Sorry, that's my phone.
Oh, how convenient. Oh, Ben, do you want to take this one?
I'll jump on anything, yeah. Throw the hand grenades in.
Okay.
Let me jump one up.
So, yeah, he's an 85-year-old gentleman, urosepsis, escalating NORAD requirements.
That'll do. He's on something now, isn't he?
Absolutely,
He's on NORAD
escalating NORAD. I'd say NORAD of 25, 30.
Yeah. Okay. So I'm looking at a parasternal long axis. First thing to note is that despite being on NORAD, his LV function looks like it's going to be down in light of the story that you told me. I can see from his ECG, there's in sinus rhythm, heart rate of 66. Again, I expect it to be higher given his support. With regards to his LV function in general, what I'm seeing is reduced function globally on the walls that I can see. His left atrium is probably not too enlarged. I need to measure it to be sure. His mitral valve function looks like it's be opening well, and I can't see any clear features of prolapse. His aortic valve looks to be functioning appropriately. His RV does not appear to be dilated. I need to see better views to be sure. So overall, I think his LV function is down based on what I'm told. I'd say he's got global hypokinesis.
Oh, when you say down, you mean?
Sorry, his LV ejection fraction, systolic function, would be mild to moderately impaired depending on the level of inotrope is on.
Sorry, what view? What walls are we looking at here?
So I'm looking at the anteroseptal and infralateral. So I've now come around to an apical 4-chamber view. Again, the most striking feature is the appearance of reduced LV function in light of being on inotropic support.
Yeah.
His LV does not look to be dilated. I don't know his underlying cardiac history. His RV looks like it's functioning normally. His tricuspid valve looks like it's closing properly. I can't see any pericardial effusion or clear identifiable cause for his increasing need of inotropes.
What are these walls? So
in the 4-chamber, this is going to be that's going to be infraseptal, anteroseptal infralateral. This one. I got the wrong way.
Yeah, that was what it was in there.
Yeah. So infraseptal, anterolateral.
Fantastic. And I'll give it to you with
An apical 3-2.
Yeah.
Yeah, it's
2.5.
It's kind of
No.
flicking in there.
Yeah, imagine it's a 2-chamber. So what's that one?
It's a 2-chamber, anterior, inferior.
Fantastic. So what are your conclusions?
So he's got moderate LV systolic dysfunction. I can't see any regional wall motion abnormalities. There's no other cause that I can see on this echo. I'd like to see what his valves are doing in terms of regurgitation. He's got urosepsis, so there's a question of whether there's infective endocarditis, which I've yet to see. So,
hang on a second, I'm not done yet. Hold on.
Okay.
Oh, actually, that's not bad. Actually, perfect.
This four?
Yeah, this four.
All right, let's have a look. So, mitral inflow in the top left on my screen. Okay, so he's got an EDA ratio of 0.8, so it just ticks over. His septal motion is down at 0.05. His lateral is 0.07, so they're both reduced. Again, indicating reduced systolic function.
Systolic function?
Sorry, diastolic function for the septal and lateral. My mistake. In terms of grading his diastolic function, I can't do that off the top of my head at the moment.
Tell me what you want to look at, and I'll tell you the values that will get you to the next step.
For his diastolic function.
Diastolic function.
So it's his LV area that's indexed, whether it's equal to.
That's less than 35. That's normal. Normal indexed left atrial size.
And then the other thing is his TR jet.
TR jet is less than 2.8, so that is again normal.
And in the setting of an impaired LV function, and inotropes, I have to go down the algorithm, but that would going to make him.
Yeah, so you're going to be in that second table if that's what we decide to go with. And again, there's arguments not, but it's the best we got.
Yeah.
So you're going to be in that second table on those diastolic dysfunction guidelines.
Yeah. So that's either going to be, if those two parameters are normal, that's either going to be normal or grade 1.
Fantastic. So you don't actually even have normal on the bottom one because
it's all going to be.
There's some form of diastolic dysfunction. So if you have any kind of structural abnormality or reduced LV systolic function, and so I take that as anyone with hypertrophy, even that's a structural abnormality, or any kind of systolic dysfunction, you will have some form of diastolic. So you're definitely in the grade 1. So as you said, we've got mild diastolic dysfunction.
Yep.
What else is on that table that's really important with this patient? So what's after we say that they've got mild diastolic dysfunction? The next thing that we say is, and it's up. It's up here. So you're
filling pressures.
not filling pressures.
Left atrial pressure.
Left atrial pressure. So what is the rest of left atrial pressure? Normal or raised?
His left atrial pressure is indeterminate.
He's not. Well, we said it's. We said he's in mild.
Yeah.
So we said he's in mild, and again, we can argue on the guidelines, but if we're going with the best we got, I think we could say he's got normal left atrial pressure. We could argue that it's indeterminate. Exactly. But we've got a normal left atrial size. We've got an E to A ratio that's into the less than 2.
Yeah.
Absolutely. So put that all together. Just tell me your conclusions again for the whole thing and put it together. So urosepsis, escalating catecholamian requirements, query, cardiac function was the request. What are you going to say about this study?
Okay. So I'm going to say he's got moderately impaired global LV systolic function. He's got grade 1 diastolic dysfunction, and from a clinical point of view, I'd make sure he's fluid replete and consider giving a bit more fluid, but apart from that, I'm not sure. Okay,
what's the diagnosis? Because again, it's a clinical exam. So if you've got all that, what are you going to say at the end of it? Why is this important?
So I guess what this does is it excludes some diagnoses. For example, it excludes catecholamine, or likely not catecholamine associated cardiomyopathy. It excludes an ischemic event.
Okay, I'm not sure about that. It could be. So to be honest, we don't even know, right? Because we can't exactly do MRIs on all these patients yet.
Yeah.
So this could be catecholamine. It's not a stress induced. It's not a Takotsubo type thing. But we've got
catecholamine. Yeah.
Microvascular abnormalities could cause it.
Yeah. Sepsis could be the cause.
Fantastic. What's that known as?
Septic cardiomyopathy.
Septic cardiomyopathy. What's the definition of a septic cardiomyopathy?
Cardiomyopathy with no other cause and bacteremia of some sort. I guess it depends which definition of which definition of septic cardiomyopathy there is. Is there a standardized one?
Yeah, good call. Fair enough. Actually, there's not a standardized one, but there's Sam's one, which is right.
Yeah.
Which is right. There's one that I from.
Good go, Ben.
So
Yeah, good call. Good call. I think a septic cardiomyopathy is a
absence of another cause.
absence of ischemia.
Yeah.
Yep. Nice.
Yep.
And another cause.
Yep. There's got to be LV dysfunction or
Yep.
cardiac dysfunction. Could be LV, RV, systolic, diastolic.
Fantastic.
And
LV or RV, systolic or diastolic. Yeah.
The time course has to fit.
So it's an acute event.
Yeah,
Nice.
And there's got to be infection. There's got to be a source of infection.
Very nice. There's got to be presumed infection there.
Yeah.
Really nice. And then often they talk about having normal left atrial pressures.
Yeah.
And so this guy's starting to
But
fit a lot.
that's acute.
Yeah, exactly. In acute, that's the septic
that's acute.
cardiomyopathy. And that's why we've got, with this normal left atrial size,
Yeah.
again, that's starting to point me towards thinking that this is acute. Because if you've got chronically
You get a big
reduced, chronic systolic dysfunction as bad as this,
Yeah.
and then with inotropes, you'd expect it to be even more,
Yeah.
and he's got the left atrial size as normal, that's suddenly starting to add up. And I would be putting on the form, this has cardiac features may be consistent with a septic cardiomyopathy, and that's what the examiners would be expecting. If you're seeing this pattern, you should be jumping forward and saying, this is a septic cardiomyopathy, and for all the following reasons. But of course, we've got to be able to exclude that there's no obvious ischemic changes, but we haven't got a regional wall, no regional walls to fit that, doesn't exclude it, of course. We've got to try and see if there's any past medical history suggestive of him having any kinds of heart failure.
Yep.
Hence the importance of taking a history. What's your exercise tolerance? Has it been decreasing recently? Do you have signs of heart failure?
Yep.
The big swollen ankles, the pulmonary edema, whatever.
Yep.
And so that's where it all starts linking together. And that's the hardest bit in all of this, right? It's linking the echo signs to that. Because this isn't just an echo exam. You're going to be expected to start putting things together on your feet.
Yep.
Because that's the whole point of it, right? And if you can't put it together on your feet in an exam, you get worried about you being able to put it together at the bedside.
Yep.
And that's when we start getting worried about making bad decisions on the spot with clinicians who know how to do this, but can't put 2 and 2 together.
Yeah.
Which is not entirely fair, because most of the time you don't get an adequate history on the request.
This is true, but in the exam, I guess I'm trying to say that in the exam, that is the expectation, that it's solid clinicians doing a solid exam. If you miss a diagnosis of, I don't know, you're missing hypertrophic cardiomyopathy where there's apical thickening, I'm not massively care about that, but I do care if you look at this and can't pick up that this has the potential to be acute. And if it's acute, it's got the potential to be reversible.
Yeah. And
I don't know, you don't want to hear someone say, oh, I'm going to palliate him because he's got a terrible systolic function and he's 85 years old, this guy.
Yeah.
This is 85 years old with urosepsis and a likely reversible myocardial depression. This is a guy that would probably be able to, as long as he doesn't go into multi-organ failure, you're probably able to, if everything settles down, this should get better with time, right?
Yeah.
And maybe that's a bad example, but you know what I mean. As in, you got to be able to put 2 and 2 together.
Yeah.
Suggest repeat echo in 5 days.
And I think that's exactly what I said.
Yeah,
I said, so my conclusion for this guy when I wrote it, it says, there is a cardiogenic component to the patient's shock state. This is likely acute and may represent a septic cardiomyopathy. Suggest repeat imaging once acute illness resolved. Nice.
Yeah.
All right. Amri, do you want to?
Yeah, sorry.
Okay.
And of course you said that.
No, I didn't. My phone is on as well.
Yeah, exactly.
All right, let's choose. This one is, I find these sometimes challenging. We'll see if I can. Okay, so this patient is in the intensive care unit. They are 91 years old. And they have come in with shortness of breath. This wasn't private, we should add, where there's insurance, there's hope. And this gentleman has come in with a background of pleural effusions. He's had cabbages. He's known to have moderate aortic stenosis, and he's come in with signs and features of congestive cardiac failure. I'll start with that one.
Okay, so it's parasternal long axis view at depth, which shows a left-sided pleural effusion, which is moderate. It's only one view, but it looks like there's severe left ventricular systolic dysfunction. The right ventricle looks of normal size, but also looks like it may have impaired function, and the left atrium looks dilated.
And
What is that there?
That's the anterior mitral valve leaflet.
Fantastic. What else do we see?
The aortic valve looks heavily calcified with restricted opening, and the mitral valve leaflets has an increased E-point septal separation.
Oh, excellent. So that too. So what does the E-point separation mean? And I'll just for those of you starting out, might be a bit of a dodgy one of doing it, but this would be the theory behind the E-point separation. So if you can put an M mode down that goes through the mitral leaflet tips, obviously you need an M mode that's a bit better than this. And then you're looking at the distance between that anterior mitral leaflet tip opening between there and there. So here we've got 1.7 centimeters. So is that abnormal?
Yeah, it should be less than 7 or 8.
Perfect.
So it's either a dilated LV or a severely impaired LV or both.
Yeah, put poor cardiac output, ejection fraction less than 40%, I think some studies said, or whatever. It's a bit of a rubbish one, but everyone mentions it. Critique this image for me.
So it's measurement of the LVOT. So it's very difficult to measure when the valve is calcified because it's hard to measure the insertion points of the leaflets. It's also hard to be sure that we're in mid-systole because we can't see that the leaflets open because they're so calcified. According to the ECG, it would suggest that maybe we're beyond mid-systole, but they often don't correlate. The aortic valve leaflet opening and the ECG are not always synchronous.
Nice.
But the timing looks like it's a bit too late. And without seeing it alive, I can't be sure that that is the right place, but this is where most of the measurement error comes because it gets squared when you're measuring the aortic valve area.
Very nice. All right, so what do you want to do? If you're worried about aortic stenosis, what do you want?
Do you want this continuous wave Doppler?
Oh, maybe can I show one more?
So that's the apical 4 chamber with color through the mitral valve and then continuous wave Doppler through, showing mitral regurgitation with a peak velocity around 5 meters per second. It's an eccentric jet on the color, so the CW underestimates the severity.
Lewis, I've got this for you.
Yep.
Lewis, how... You're going to love this.
It's out of that.
All right. How severe is the mitral regurge?
Based on the apical 4 chamber with color.
I don't know if I can zoom it in for you. Nice.
So the scale's set to 59, so it's just below what's recommended for ASE quantification. It looked like there was a fairly eccentric jet, but still hitting the back of the left atrial wall, which itself was dilated. So there's quite an extensive jet. There's evidence of flow convergence, and without sort of panning through the valve to get a best idea of the vena contracta, it looks like it's going to be significant. So I would say at least moderate, possibly severe.
Yeah. Is there any other feature on this color Doppler? As I've frozen it in mid systole. It's a new finding that you sent me the other day. That's why.
Thank you. Display sign. Yeah. Now you've frozen it. I can see it.
Yeah. So what's the display sign? It was awesome. So this is Lewis.
First time I've seen it in the wild.
Say again.
That's the first time I've actually seen it in the wild, having read that paper.
Can you describe it to everyone and take the glory?
Sure. It's can you put your cursor over the areas? So that color Doppler change on either side of the flow convergence area has been described as a side lobe artifact of the color Doppler. which in a series which was published was associated with at least moderate, probably severe regurge.
Right. I'm not sure you need to bring that up in the exams, but I saw it just then and I thought of you, so it's called the splay sign.
Why didn't you send it out to all of us? You rotter.
Yeah, maybe, absolutely. Maybe send it around to everyone. I thought it was pretty
I
cool.
will. I will.
It's a little geeky. Don't start with a splay sign, whatever you do when you're starting to describe it. But it was
the first thing I mentioned.
So is the point
cool.
that it's not a side lobe artifact, or the point is that it is?
It is.
So it's a side lobe artifact, I think, because you've got such incredibly fast, flow coming through a big hole, I think. All right, let's get back to what the whole point of this actually was. Sorry, let's go. So you wanted the continuous wave Doppler through the
Aortic valve.
aortic valve. Oh, sorry, Lewis, while we're on it, just tell me, sorry, doing the mitral regurge, just stick with that. I'm going to show you this picture as well.
Yeah, consistent with severe mitral regurge.
Why?
E wave is greater than 1.2.
Fantastic. So E wave greater than 1.2. Here we see a 1.4, 1.4. That's an enormous E wave, particularly on someone's, got a bad systolic function where classically you have raised left ventricle pressures, right? So that huge E wave suggests that you've got an enormous amount of blood coming through the mitral valve. He's not in a high flow state. Sorry, he's in a high flow state, not because of the tachycardia or an increased heart rate. Because he's got an enormous amount of blood that's come back into the left atrium that's then coming forward into the left ventricle because he's got severe MR.
Can I? Sorry, the diastology then. Do you just say indeterminate?
I think you can use other things. I would argue that you've got to say that there's significant. I'd say something like significant diastolic dysfunction with because we've got these E primes. So E primes are really good in the critically ill. I think they talk about impaired relaxation, and I think if you've got the MR as bad as it is, severe MR, I'd say significant diastolic dysfunction. That's a wonderful word to get you out of trouble with raised left atrial pressure. So if he's got signs of CCF, we'd be saying that there's a significant valve problem in there. All right, where are we? What is that? That is. I think that's it. Yeah, go for that.
So that's apical 5-chamber with continuous wave Doppler through the aortic valve, showing a peak velocity over 4 meters per second. It's almost 5 meters per second on the second, which would be in keeping with severe aortic stenosis, except it might be pseudo-severe.
Tell me why.
Because the LV function is so poor, if you increase the LV function, the valve may open more and the velocity may actually drop.
Beautiful. Does that make sense to everyone? Do we understand that? So the idea is this severe or not? We've got a bad LV function. So if we particularly did that one with, where's my LVOD?
So your DSI should still be accurate.
Yeah. I think I'll do it like that. Hang on, let me do it like that. So here we go. I've got a Vmax. I think the wrong one's been recorded, but you get the idea. So we've got a VTI here of 50. We've got a VTI here of 13. So we've got a actually I've chosen a bad one, haven't I? Let's actually measure it. It's not going to be great doing it in this, but you get the idea. Makes you wonder whether we're in the MR or not. 4.9. I wonder whether we're actually in the MR there. Let's just go back and have a look.
155, your VTI.
Yeah, I think that sounds ridiculous, right? Because that looks. So how would you tell the difference between mitral regurge versus aortic? Sorry, mitral regurge versus aortic stenosis? Because that's what we're worried about there, right? Because I think we've got to look at it in multiple different angles. Don't forget to do that. and it was that one there. So someone's obviously trying to have a look. So my question for you is that mitral regurge or aortic stenosis?
So if it's mitral regurge, there'll be isovolemic contraction before the flow.
Very nice.
And then the shape would be the other, and whether but it's mainly the.
So that one there.
It's mainly the duration.
So good notes, the duration, right? So if that one, see if I can show you both. So this might be quite, maybe I can just use the LVOT. Nice. Okay, that's a beautiful way of trying to show it. I think we can show it there. So having a look at that and having a look at that, this is definitely aortic flows because I can see the little dip in there of the LVOT. All right. Peak velocities 2.5 versus the other one that's 4.5. So classic when we're getting over 4, that's, you know, that's either severe AS, but that's a ridiculous gradient with a valve, with a ventricle that's functioning that badly. Okay, we got severe systolic dysfunction. You got gradients of 4 or over 4. That doesn't make a lot of sense to me. And can you see? I wonder if I can actually time this. Oh, you bugger! Okay, went back. Let's go that one. Let's do that one, and let's do measure generic time. So look at the beginning of this one, right? So the beginning of that mitral wave is just before the QRS complex. Yeah. If you then look at this one, it's just after. You can get it here. It's just after, right? So that means that that is the mitral regurge because you've lost the isovolumetric contraction and relaxation. Yeah,
So that's the way I have been looking at it. Is that's the most correct? So basically, if the if flow starts at the onset of the QRS or at the R wave, it's probably MR. But if it starts at the end of the QRS, then it's probably aortic.
I think the caveat's got to be that the electrical wave activity sometimes doesn't exactly match up with true beginning of systole and end systole, because again, the definition of beginning of systole and end systole is when the aortic valve actually opens or closes. So you can get a little bit of discrepancy, and they've shown that with strain stuff. And again, maybe we're getting into more researchy based stuff here. The best way of doing it is comparing two next to each other and just seeing how they can compare. And just, I think you just say whichever one starts first is going to be the mitral one.
Yeah.
Yeah.
Yeah,
so
yeah.
Try not to use the ECG as being absolutely true.
If I mean, what if you're struggling to sort of differentiate the two, though?
So I think it would be trying to take a picture of both, so you can, you know, try to get the MR, I guess, different angles, and just looking at it and then comparing the start time if you've got two different traces, I guess. That's sort of the best I can do. So you've got to be able to try and find separate traces, I suppose, and then you'd know that the later one was definitely the aortic flow.
Okay, no other trick.
It's a classic question, right, with the LVOT dynamic obstruction, right? That's a classic exam question. If you do the ASE exams, I guarantee that's going to come up. There'll always be how to differentiate MR from LVOT, and that's all about timing. Nice one. Sorry, I haven't gone through enough. Kylie, do you want to go?
Maybe. So long as it's not transesophageal.
It will not be. It will not be. Let's do this one. Okay, so this patient's peri-arrest, brought in by ambulance, incredibly short of breath. Peri-arrest state. History of a pacemaker and a cardiomyopathy.
Would it be possible to look at the lungs first?
No. The lungs are filled with water and a pleural effusion.
Okay.
I don't have
Yes.
lungs.
All right.
There's a lot of
So
strain.
this is a parasternal long axis view
Very good.
with a very large pleural effusion at the back, and then some thickening that might be collapsed lung attached near the pericardium. There is, starting from the top of the picture, there's a pacing wire in the right ventricle. The function of the right ventricle looks fair, and the size doesn't look particularly large if you want to compare it to the aortic root or the left atrium. The aortic root looks reasonable size, relatively speaking. The aortic valve's opening cleanly. The left ventricle looks maybe a little large, but not huge. The mitral valve isn't opening very much. Both the interventricular septum and the posterior wall and the papillary muscle look quite thickened. The walls are kissing. You'd have to be very concerned about the LVOT obstruction. That's probably as much as I can say on this one. But also, the descending thoracic aorta is there, and there's an odd hypoechoic sort of mass to the screen right at the bottom that I'd like to investigate a bit. Much lower than that. Investigate later. Yeah, that bit, don't know what that is. I'll have to come back to it.
Second?
I'll come back to that bit.
No, it's not the vertebral. The question was, is that the vertebral body? And I'm going to say no to that because
No, I
we've
don't
got
think so.
something behind it because they'd expect artifact. And also there's that in there. And I think that is a reflection of that. Yeah. So I don't know exactly what that is. I'm guessing that it could be a stomach filled with lots of fluid potentially.
Just very occasionally, if you happen to be scanning through the intercalated disc, you can actually see the spinal canal at the back. But I don't think that's what it is in this one.
How do you differentiate between a pleural effusion and a pericardial effusion?
Where it goes in relation to the descending thoracic aorta. Beautiful. This one seems to be going posterior to descending thoracic aorta rather than splitting it off from the left atrium.
Pay that.
Okay, so we've got a parasternal short axis view at the level of the papillary muscles. We can see on the top left of the screen the tricuspid valve and the right ventricular outflow, or right ventricle anyway. The tricuspid valve, just interestingly, doesn't look normal to me. It doesn't look like it's opening widely. And I can see a bit of the pacing wire again in the right atrium. Be nice to put color flow on there and pulse waves in both directions, pulse wave Dopplers. Looking at the left ventricle, the shape of the ventricle isn't particularly round. You'd be concerned about some D-shaping the interventricular septum. And again, you seem to have hypertrophic walls pretty much the whole way round with a low volume within the left ventricle. Does seem to be, now there's a tiny bit of fluid posteriorly. I wonder if that's pericardial effusion. It seems a little bit high to be the coronary sinus. It's not quite disappearing in diastole, but at the same time, I'll probably class it as trivial until I see more of it.
And again, it's only physiological if it disappears during diastole. So that's still present during diastole. So that is a small pericardial effusion because it's less than 1
centimeter. Yeah, okay. Yep.
But no features of tamponade.
No.
And then a D-shaped septum, is that a volume or a pressure load? Is that a volume or a pressure overload, RV?
Okay, so I'd have to decide whether it's happening in systole or diastole. If it's in systole, it will be a pressure overload. If it's in diastole, it will be volume.
That really helps. It's sort of during systole. So you see it's coming in systole from beginning of QRS to the end of the T wave. Looks like it's coming in with that. Maybe a pressure overloaded system.
Okay, apical 4-chamber view, where you can now see what I think is a small pericardial effusion just near the right apex. The right ventricle is larger than the left ventricle, which makes this moderate severe right heart enlargement. What else to say? the overall function of the left ventricle appears, I'm not happy with it. The mitral valve leaflets aren't moving terribly well. Both atria appear large. We do expect that the right atrium will be big because there's a pacing wire, so there's going to be some tricuspid regurge, but they've also got round bottoms on the atria. The interatrial septum's not dancing side to side. So that fits with the right heart strain and the D-shaping the septum that we saw earlier. The right ventricular wall's really sort of thickened and chunky, and the moderator band is prominent, and the TAPSE is obviously going to be really, really poor. The tricuspid annulus isn't moving very far at all.
Fantastic.
So have to say this, I would be worried that this is a secondary failure of a chronic right heart strain. The fact that the right ventricular wall is thickened and the right atrium is big speaks against a hyperacute phenomenon. Yeah, but
Nice.
I mean, it's
Very
still
good,
possible
very
that he's got a small P on top of chronic right heart strain. I still want to see the lungs in the IVC. Oh, you're going to show me
All right,
wavy
Sid,
things.
let's
Oh,
move on
dear.
to Sid just to give him a chance in the last few minutes. So Sid,
Praise
I'm
the
gonna
Lord.
give you...
Thanks, Sid.
That was great work, Kylie. Okay, Sid, I'm going to give you... bugger, bullseye. So that one is that one. That one is that one. All right, Sid, talk to me about diastolic function.
Yep, that's what I was
You've
concerned
already seen that
about.
one, that's tricuspid regurge. There's the TR.
Okay, so top left, this one.
Yeah,
top
just give me the diastolic dysfunction. What grade is it?
Okay, so the septal E prime is about 3 to 4 centimeter per second, and the lateral one is about what 2 or 3 or 4 centimeter per second. So it's with the this is E wave, I'm guessing E2A. So E wave is 0.8 and the A wave is 0.2. So the ratio is going to be around what 3 to 4.
Yeah.
So this looks like and coupling it with the severe tricuspid regurgitation, which is about 2 or 2.4. No, sorry, 2.2.
Yeah, it's only 2.
It's probably a severe or grade 3 diastolic dysfunction.
Fantastic.
Looking at the images with the LV hypertrophy and the dilated left atrium and the tissue Doppler imaging.
Okay, I'm going to make a couple of measurements for you. So both the medial and the lateral are less than 5. The S prime is less than 5, and we've got a restrictive filling of the left ventricle. What is the potential diagnosis, Anne-Marie? Amyloid. Beautiful. So there's what's the 5-5-5 rule?
Yeah. That the medial lateral left tissue Doppler and the S prime are all less than 5, but it's also thick and definitely has restrictive diastole.
Very nice. So this patient's cardiomyopathy is amyloid, right? Because we've got this relative hyperkinesis of the apex versus the basal segments. We've got huge atria on both sides, small pericardial effusion, thickening everywhere, just like Kylie described very nicely, and thick ventricles with a little speckled appearance. All right. And so all of that you can then do, that's all the strain imaging was meant to show at the end, which is just a bit of a, I don't know if I've actually got the little bullseye plot.
There it is, cherry on top.
So we've kind of got pictures here. You get the cherry on top. I don't know if I've actually got the bullseye. Maybe I could.
Yeah, you do, Dan.
I think so. Let me. Sometimes if I go Q analysis, no, 2D strain. Proof. Quad. No, sorry, I don't have it. But what we're looking for in the in the full picture is a cherry on top and a bullseye. And that gives you the indication of amyloid, again, that regional wall motion abnormalities, excuse me. And I made the whole thing bloody freeze. Yeah.
Ask two questions, Sam. Can you just, what was the 5-5 rule again?
So if you have the E prime of the medial and the septal annulus less than 5,
yeah,
and the S prime less than 5 as well. So that's suggesting bad systolic and bad diastolic function.
All your TDI measurements.
All your TDI measurements. And again, that's in the absence of any bundle branch block, which I guess we could argue potentially we've got here, but bundle branch blocks, mitral annular calcification, AF or whatever.
Yeah.
The 5-5-5 rule is associated with, not pathognomonic, but just associated with amyloid.
Restricted cardiomyopathy or amyloid?
Amyloid.
Okay.
And then particularly that it's the regional wall motion abnormalities, the restrictive filling, the pericardial effusions can be there, the thick myocardium, the very thick myocardium with the speckled appearance. And the speckled appearance is less when we start using harmonic imaging, but we still talk about it.
Yeah. And did you think there was EA fusion there?
No, I think there was an A wave in there.
So the Eon A was about
3 or 4.
Well, so Eon A is about if it has to be over 0.2, doesn't it? For it to be...
2. It's got to be over 2. So if we did that and that, I've got to ETA ratio 3.36.
So I guess I'm saying whether there's fusion, because you have to have a
oh, I see what you mean. Yeah. You mean you've got to drop down and actually have a better gap that's in there.
Yeah, less than 0.2 is.
Yeah. Oh, I see what you're saying. I mean, I can fudge that. Come on, hang on.
It looks like it's about 0.2. So would you?
I'm gonna. Oh, hang on a second. Because also I've got my gain too high on this one, and I wonder if I can actually change it down.
Yeah, nice.
Yeah, that's how we change it. Because again, you see, it's quite overgained, isn't it? I just wonder if I can actually change it while I'm here. I don't think I can. Let me just go back to that. There we go. It doesn't really work very well, does it? I think if I was to turn that gain down, like down here, I think it's actually right down at that point there. If you can see my cursor, I think that's where the change is. I think all of this stuff is overgained. You see that's bright white in there? I think it's down there, which is less than 0.2.
Yeah.
All right. Great work, guys. I hope that was useful. That's just kind of gives the example of how the exam works, but more importantly, I just think some good pathology in there.
Thank you.
Any questions?
That was great. Thanks.
Cool, guys. Thank you very much indeed. Have a good one. See you next week.
Thanks, Sam. Bye.
Bye.
Can I just ask a question about the U wave?